Back, how do I grab this button right here? Oh,
Face this. Did you accidentally press this button?
I pressed hold, I think.
So just don't press the top.
Whoops, my phone might have hit the end of it. Just like.
That's incredible. They're going, and then what's in it, probably just be. Certain people that can do that.
I know.
All right, next up, we have Sophie Moore, one of our physician assistants for Dr. Flannel. She's brand new. She is from Charleston originally. She went to Newberry College and was an athlete. What sport did she play, Bree?
Women's lacrosse.
Women's lacrosse. So she has an athlete. Not only does she treat athletes, but she is an athlete. So without further ado, I'll let you.
Slightly retired athlete, just a little washed up. So a little bit about me again. My name is Sophie. I'm Dr. Flannel's PA. So everybody keeps saying, "Oh my gosh, Dr. Flannel got a PA?" Yes. The short one following him around all the time. So yes, I am from Charleston. I grew up in Mount Pleasant. I actually went to Wando High School, which gets a lot of booze around here. And I went to Newberry as a major in biology with a minor in psychology. And then I went to PC for PA school and I graduated in September. I know we're a little bit short on time and we've got a schedule, so try not to take too long going through all of this. But my presentation is a focus on just ACL tears in a female athlete. Obviously, I played high school sports, I played college sports, so this is something that's been a passion of mine for years. So I'm really fortunate that everything worked out and I passed all my boards through PA school to get to this point where I can see patients, treat all our athletes. We take care of pretty much all our surrounding high schools, Ridgeview, White Knoll, River Bluff, Lower Richland, Blythewood. We take care of SC State, we take care of the Fireflies. I mean, pretty much anyone and everybody is who we will see. So just to start off, I just want to talk a little bit about knee anatomy. Which I'm sure everybody knows where the ACL is, but just in case, the ACL attaches at the medial aspect of the lateral femoral condyle and attaches in the intercondylar notch. So it's just a helpful picture there. So one thing I really want to focus on in the beginning, especially when we're talking about female athletes and ACL tears and female athletes, is understanding why they're at increased risk. I'm sure we've all heard that there's been a lot more ACL tears over the years in female athletes. So we got to start out with the Q angle. So what is the Q angle? The quadriceps angle. This is defined as the angle between the quad tendon, the quad muscle, and the patellar tendon. So it's measured starting point from the anterior superior iliac spine to the center of the patella. Sorry, I'm short, so I might be pointing at something you can't see. The second measurement is from the center of the patella to the tibial tubercle. So that right here forms the quadriceps angle. And so these measurements are super important to understand because, again, this is a big difference in females versus males. So the average Q angle for women is 17 degrees, while it is 14 in men. The range in women is 13 to 18, and the range in men is 12 to 15. So what does this mean? The larger angle means there's more pull on the patella. So we'll kind of get through to the next slide. In women, this is going to increase the stress of the quadriceps tendon. It's going to lead a little bit more to instability of the knee. Males don't have as large an angle, so they don't have more of a lateral pull in the patella. This, in a lot of athletes, especially female athletes, leads to patellofemoral pain syndrome and patella maltracting, which we see a lot in our office, and it's usually something that can be fixed with physical therapy, seeing athletic trainers at the school. But again, this is something that contributes pretty greatly to ACL tears. And again, if y'all have any questions or need to stop me or anything, please just let me know. Just raise your hand. So we're going to kind of start with going over the epidemiology and risk factors of ACL tears in men versus women. The three main points that we want to focus on with the female athletes is the anatomy, hormonal differences, and biomechanics. So we pretty much just covered the Q angle, the differences in females and males. But one thing I think has been in research a lot and something that's being talked about a lot is the hormonal differences in female athletes. And then biomechanics, we'll get into that later on, but women tend to land more upright. They have increased knee extension, a little bit more valgus alignment, so the knee tilts inward just a little bit more, and naturally decreased muscle mass of the quads and hamstrings in comparison to males. So let's focus a little bit on the hormones and menstrual cycle. Average age for most females, first menstruation is 12 years old. Then we see a huge rise in ACL tears in women age 14, 17. Personally, I've seen this as a coach. I coached lacrosse for Wanda when I finished with undergrad while I was preparing for PA school. And I saw girls that were tearing their ACL at 13, 14, would have surgery, rehab, and then tear the next one. I mean, it's just brutal. You're seeing it left and right. It's 2 to 8 times more likely in the female athletes than the men. I mean, to me, that just jumps off the paper. That's massive. That's a huge difference. Why is this? Well, in the beginning, puberty, we have fluctuations in weight. When the menstrual cycle starts, an increase in hormone fluctuations in weight, increased BMI, which obviously puts more stress on ligaments and joints, and our muscular strength may not be also matching, our increase in weight or counting for that. So, how do these hormones affect ligament laxity? Estrogen and progesterone reduce ligament strength and cause flexibility. So, throughout the menstrual cycle, you'll have a peak in these hormones. And again, we'll kind of discuss this a little bit later, but is it possible that there's a correlation between the hormones and laxity of ligaments? I think absolutely. Ovaries release the hormone relaxin during the menstrual cycle. Ligaments actually have receptors for relaxin that breaks down collagen and softens their strength. That's huge. That's another automatic disadvantage when we're talking about female athletes before we're even getting into prevention, strength and conditioning, anything. It's just simple how God made you, your anatomy. So again, women are at increased risk for an ACL tear during this time. Any questions so far? So this is something I wanted to focus on. Like I said, we've been seeing a lot of research and a lot of people talking about hormones and the effect this has on ACL tears. So I think this is a pretty big study that's starting actually right now by FIFA, what is, in my opinion, one of the biggest sports organizations in the entire world. In April 2025, FIFA announced that their organization would be funding a study conducted in England examining the role of hormones in ACL tears in female athletes. So I think that FIFA is stepping in to say, hey, we do think this is happening. We do think there's a huge effect with the menstrual cycle on ACL tears, and they're obviously putting their foot forward to put the study out there. I think it's a pretty big deal. So what this will consist of is professional women's soccer players from the Chelsea and Fulham clubs, some other surrounding a little bit smaller clubs will have their blood analyzed throughout the menstrual cycle, which will monitor their hormone levels. So when they go in there to have their blood monitored and their hormone levels, the athletes will also undergo a series of physical tests to assess, the effects of hormones on ligament laxity and ACL tears. So some of these tests might be like jumping, putting, and just seeing how their performance is and seeing if there's any correlation. So it'd be really interesting to follow this and see, what kind of positive correlations there are, because I think there will be pretty big ones. And I think, with this study as well, and some of the other research out there, in the future, could this information kind of help change training loads for female athletes at the high school level, at the college level, all of the above, I think would be a big deal. So, biomechanics. Women naturally land more upright in comparison to men. When we jump up, we tend to land a little bit more in extension, our knees buckle in, we're not absorbing the ground, as much as some male athletes will. And this obviously is going to contribute to increased ground forces exerted on the knees. So you don't have a lot of control, you're jumping up, you're coming down, there's a lot of force coming through the ground versus if you land very stable with your knees bent and you're very straight. So again, increased valgus alignment due to increased Q angle. That's not something that women can necessarily change. It's just part of the anatomy. But again, increased extension, stress on the ACL. It's like a rubber band. The more you're stretching the leg out, you're landing on it, you're not absorbing it. That ligament is being stretched just like this, especially with your knee pointing inward. So it's a lot less risk if you're landing properly, not an extension, and your knees are less bent. Decreased muscle mass, weak muscles, instability knee. This isn't just about muscles surrounding the knee, but it's the whole leg. We're talking about, from the hip down. So it's not just one thing that matters, it's the entire leg that contributes to the muscle weakness. Again, more decreased muscle mass, diminished control for cutting, pivoting, jumping. So it kind of just goes in a cycle. So I think this is a really good diagram that illustrates, biomechanics, especially in female athletes. Obviously over here on the left, this is, showing, good jump, landing with your knees bent, not poor control, knees like this, falling over. That's what we're seeing in the picture to the right. And again, it's also about hip control. It's about muscles going down the full leg. So I think this is really picture to keep in mind when you guys are seeing a ton of athletes, way more than we're seeing on a regular basis when you're working with them in the training room, when you're helping with their rehab, just all of the above, even if they're coming in, may not be for an ACL tear, but another issue. And y'all are seeing this on a daily basis. So if it's something that, you can fix or pay attention to, I think is really, really important. So these are some of the additional risks and comparisons among female and male sports. These numbers in this research was taken from Project Play, which I'm sure maybe some of you have heard of, from the Aspen Institute, Washington, D.C. And basically over the course from like 2007 to 2022, in like 3-year spans, all athletic trainers report to the amount of knee injuries, ACLs that they see per 100,000 exposures. Exposure is when an athlete is in practice or at a game. And so we're monitoring that data to show what sports have the most ACL tears. So women's sports, women's soccer is number one. That is the highest amount. I'm sure you guys see that also on a daily basis. This is followed by basketball and lacrosse. Lacrosse has had a huge increase. I want to say when I was reading through some of the research that over the past few ACLs that they've had per the 100 exposures, it's like 8 out of 10 are non-contact injuries, which is that's crazy. In men's sports, it's men's football, lacrosse, and soccer. Higher rate of ACL tears in spring football. Why is this? Because they're coming out of a time where it's the off season. They may not be training as hard. They're not doing the strength and conditioning that, they may be used to in the middle of the season. So I think, again, that's kind of something to note for our coaches, for athletic trainers, not jumping right into it, not going 110% when these athletes may not be ready. And that, again, same goes for female athletes and their sports as well. So one thing as well I want to point out is contact versus non-contact. Huge difference in female non-contact injuries in comparison to male. Why is this? The anatomy, the biomechanics, the hormonal differences, those are the big things. So we have to pay attention. Well, we have those things that are contributing. What can we do on our end to try to prevent it? Another thing I wanted to point out was during 2020, 2021, during the time of COVID, time of pandemic, rate of ACL injuries grew more than any other year. Again, most likely due to less training, conditioning, and strengthening. I think we're starting to see a trend here. Spring, when athletes are in their off season, ACL tears go up. When there's less training, conditioning, strengthening goes up. You may not have, athletes that have the coaches around, people watching them train, all of those things I think contribute. But again, the rate of non-contact ACL injuries in females is massive in comparison to males. So, diagnosis and recognition. This is kind of the clinical point of view. Again, I was a college athlete, now I'm a clinician, so it kind of puts me in an interesting space where I can understand where a lot of these athletes are coming from and then also have the clinical view as well. You guys are the first to see them always. You're the in between before they come and see us. So first things to recognize shortly after injury, knee effusion. Huge. The knee is going to be massive. This isn't just swelling of the knee. This is swelling and fluid buildup inside the joint. This contributes to a lot of pain for the athlete. This is a huge source of aggravation for them right after a tear. This develops quickly after major injury, especially in ACL tears. Ice and elevation is key. So in the meantime, before they're coming to see us or going into a different office, gotta be ice and elevating is super important. Trying to stay off of it as much as possible. Another test you might do on the field, I'm sure many of you guys have done it. Lockman test, athletes lying flat on the ground, knee is flexed slightly, you're stabilizing the femur and you're pulling the tibia forward. Obviously an ACL tear, you have a lot of increased tibia translations. That tibia is moving forward a lot more versus you have a hard stop when an ACL tear is less likely. But sometimes this is hard to feel right when they're injured, when they're on the field. So it may not be something that you recognize right away. But again, they're going to have a ton of swelling. That's going to be the first thing that you notice. This needs to be seen quickly. So again, from the clinical view, some of you may be familiar, some may not. We have convenient care as a part of Prison Health right down the road. We have a Lexington office and we have our Northeast location as well. I believe their hours are 7 a.m. to 7 p.m. You can bring them in there or guide them in the right direction if you have an athlete that you think has an ACL tear that needs to be seen. They can be seen, again, convenient care. They can come to us if it's during normal hours. I'll give you our contact information and we'll get to that as well. But when we get them into convenient care, providers can perform a knee aspiration, again, pulling all that fluid off the knee. Do not believe how much better a patient, the athlete feels when that fluid comes off. It is like night and day. And that can really help them when we start talking about what our next step of treatment is going to be. But the faster that we can get them in to see somebody, they can get a knee aspiration, they can get some medications, and we can already go ahead and see them and start getting an MRI for definitive testing. And we can do this pretty quickly once they're seen in office as well. So that's a big thing in communication and getting the athlete seen as quickly as possible. So again, this is more clinical side of things, but just in case, talking about surgical treatment and common graft options. So again, we send athletic trainer notes all day long, and we're putting abbreviations and surgical techniques and all that kind of stuff on there. So again, it's good to know these different graft options and what each athlete has going on. So surgical treatment, common graft options, quadriceps tendon, hamstring tendon, patellar tendon, and allograft. There's a few additional ones, but those are the common ones. It's really important to pay attention to the re-tear rates as well. Quadriceps tendon is 2 to 3%. The patella tendon is 2 to 6%. The hamstring tendon is 3 to 20, and the allograft is 15 to 20. We'll kind of talk about what our team does, what Dr. Kleinel does, surgically wise in comparison to some of these graft options. And one thing he and I actually discussed about putting in this presentation as well is you may hear something called the Bear implant. This is kind of a little bit of newer technology, but some physicians, some surgeons are doing it. It's like a collagen and protein-based implant. It is sutured to each ends of the tear, and then it's supposed to form a bridge between the tear over time due to natural healing. But this is a 30% failure rate.
That's mainly from the PT end of it.
Sorry.
That's mainly from the physical therapy end of it, not from the doctor end of it, because they're doing too much too soon.
Right.
If they can do a lot more stuff within the guidelines, it has a very good success.
Right, and this is something that Dr. Kleinel, he doesn't do. He uses different grafts, but this is just something that is an option that we did want to put out there and put the information out there as well. Does someone else have another question? So I just want to talk about a little bit about the treatment process in our clinic. Dr. Pomo, he uses two main graft options. He prefers the patella tendon and quadriceps tendon. This is, the body's, their own tissue. The positive, both are the body's own tissue, better healing and compatibility. With both of these grafts, this is not something that we tell an athlete, this is what you must have, this is the graft you have to have. We discuss this in depth. We give them all the resources and we let them choose. Sometimes an athlete's coming in there and they choose the day of surgery what graft they would like. But it is important for understanding kind of how their healing will go after surgery, what their therapy will be like. For some cons, like again for the patella tendon, a lot of athletes will have chronic knee pain with the patella tendon graft. So again, this is something that physical therapists might be seeing, athletic trainers might be seeing. So again, it's kind of good to know what graft they may have. And with the quad tendon, this is what Dr. Pommel prefers for pretty much all athletes. He's had great results with this. It's a larger piece of tissue, decreased incidence of chronic knee pain, just a very strong graft option in pretty much all athletes. And one thing I also wanted to put in here is just kind of additional support in the surgical technique is what's called the lateral extraarticular henodesis. So a portion of the iliotibial band is taken, it's secured to the lateral femoral condyle and attaches on the lateral aspect of the tibia. So again, for example, female athletes, especially those playing soccer, lacrosse, basketball, this kind of added piece in surgery allows for a lot more stability and protects against rotational movement. So you're kind of adding another piece of stability than just the graft itself. Again, beneficial for young athletes, those who play sports that require intense pivoting and cutting, especially those that we're seeing in young athlete. I mean, I think the youngest we've seen, some of the youngest like female athletes we've seen in our clinic with ACL tears have been 12 and 13 years old. They don't want to give up playing sports yet. We don't want them to. So what can we do, on our end to make sure we keep them active and keep them in sports? This is that additional piece of surgery. So I wanted to touch on a little bit about the rehab. Again, this is more of the physical therapy focus, but it's also in the athletic training room. It also starts with, there's a lot of patients, and I know we've treated a lot of athletes that, they go to the training room at White Knoll or they come into River Bluff and, they may not even be seeing a physical therapist, but they're coming to the training room for their treatment. So that's huge. It's really important. We send a lot of patients for prehab before surgery. So full range of motion in the knee prior to surgery, that's a must. If they don't have full range of motion, they're not going to have full range of motion after surgery. It's another important thing to note that usually the athlete will start feeling a lot better after the injury. Maybe even a week or two later, they're like, oh, I'm feeling great. But we're like, but you're not running, you're not pivoting, you're not doing anything yet to test it. And we don't want them to get any kind of secondary injury because they're like, well, it's fine now, I can go play. Not just yet. The knee is still very unstable. But it's really important that whether they're working with a therapist, working with y'all at the schools, that they're getting full range of motion prior to surgery. Again, it's not something I'll go into all the detail about post-op rehab, but it is conducted in phases. The first phase focuses on, gait, range of motion, decreasing swelling. Second and third phase, you're getting more into some strengthening, balance, normalizing the gait. And then you start to see more sport-specific training in the fifth and sixth phases, introducing jogging at 5 to 6 months, supervised pivoting, cutting at 7 months plus, return to activity, return to play testing at 9 months. So that's kind of a broad overview of how rehab, post-op rehab works. But again, I know you guys work with a lot of the athletic trainers. I know, a lot of the athletes work with y'all's athletic trainers. I know when I was at Newberry, one of my roommates, she had a torn ACL and she was working with Bree a lot for her rehab and therapy. So I don't even think she went to any kind of other outpatient physical therapy. She was working with athletic trainers. So y'all are huge in the component of how well these athletes do post-op as well. So most importantly, prevention, especially in our female athletes. This is just absolutely vital to preventing any kind of injury. I think one thing to note when we're talking about prevention that's not on here is also getting adequate rest. I think we're seeing a lot of athletes now that they're playing club, they're year round, they're not specializing in any sports, they're staying in one sport all year. So they're not using maybe different muscles, different aspects of their leg they would use in other sports. They're not getting rest time, and that's putting a huge amount of stress on the ACL and any the possibility for any other injury. So one thing I want to note, just kind of going down here, is not only is it about the knee, but hip strengthening as well. Importance of plyometric exercises, single leg squats, clamshell, side planks. Again, it's not just the knee, it's the whole leg that needs strengthening. Quad strengthening, and those exercises that are listed that I'm sure y'all go through, y'all see on a daily basis. Proper coaching technique. This is super important again for female athletes in specific sports. Does women's soccer need the same strength program, strengthening, stretching the routine that football has? Absolutely not. It has to be very specific to them because, as we've seen in the beginning, anatomy, biomechanics, muscle mass, all those things, the hormones, the hormonal changes, it's all different. So it needs to be specialized based on female athletes, based on their sports. Again, coaching guidance, making sure that, I think we as y'all as athletic trainers, us as clinicians, everybody in between, we have a huge responsibility to make sure that these athletes have the right coaches, the right guidance, making sure they're not getting pushed too hard, making sure they're doing the right things, building confidence, making sure their mental health as well, which we just talked a lot about it. But I think those really contribute as well. Stretching and warm up, stretch routine, dynamic warm up, stress importance of taking it seriously. Like all athletes, I did not believe that stretching was important whatsoever. And then every fall season, I would try to sprint down the field and I'd pull quad, literally every fall. You can ask Bree a little bit more about that. So it's very important to make sure that these athletes know how important stretching is. So much of what we see in clinic, it's usually they're not stretching, they're not doing strengthening, they're not doing the prevention. So one thing we always talk about is, you're not gonna try to just go run a marathon without training. You're not gonna play your best in a game if you're not training. So let's make sure we're doing those things. It's super important. On a personal level, when it comes to strength and conditioning, Wando High School did not have most of their women's sports doing strength and conditioning when I was there. Just wasn't really a thing. So when I got to Newberry as a freshman, I was very undersized, had never been in a weight room in my life. I think I could like barely lift the bar and could squat like no weight. Then by the time I was a senior, I had been in the weight room. I think my squat increased to 155. My bench press was 75. I was running a 7:15 mile. I was never injured. I played every single game my entire career for 4 years. I never got hurt. So I 100% believe in strength conditioning, nutrition, sleep, the rest. Those are things that are super, super important. Making sure that these athletes are getting the rest they need. And again, not to hate or say anything negative, but with a lot of parents now, we have some parents that come into our clinic and they're bringing an athlete in, or athletic trainer has sent us an athlete and the parent is in there and it's like, well, their shoulder's been bothering them. We've been doing some of this, but they have a tournament in Indiana next weekend. Then we go to Louisville the next weekend, and then we go to so next weekend. Well, that's why they're hurting, because they're not getting enough rest. They have to be getting enough rest. That is super important. So just this again means that I'm passionate about things that I think I've seen a difference when I was playing. Things that I see a difference with clinic is those doing these things, proper nutrition, rest. They do a great job, especially our female athletes that are doing strength and conditioning. They do a great job in their sport, and they're not having any kind of injuries. So I want to also touch on a little bit about the limitations in rehab. One thing that we see immediately after ACL surgery is the quad becomes super weak. Pain and swelling is not managed. That's number one. When you see an athlete that you're working with and they're talking about pain, they're talking about swelling, they're working on their rehab after their ACL. The second they have swelling in the knee, we want to know about it because you cannot build up quad strength or do improve or move forward without having a decrease in swelling. And you guys are the first to see that. We're the last people to see that. So that's super important. That y'all are looking for that you see that, especially if you feel like the athlete is not progressing as they should. Again, achieving full range of motion, extension is most important. Dr. Plano loves to tell our athletes it's mind over matter. There's a lot of mental humps when it comes to getting through an ACL tear. Especially I think, we have seen an increase in female athlete ACL tears. They take it very hard. We have a few right now that, they're committed to play college sports. They're excited about that. Man, now they just tore their ACL. Like, how do I move forward? Having great therapists, having great athletic trainers, mind over matter. You're gonna have to push. It's not going to be easy. It's gonna be difficult, but again, that's why we have all these great people in this room to help all these athletes. We're all passionate about the same thing. So, but the quad weakness, the swelling in the knee, those are things that we want to address as quickly as possible. So I just want to put up here our contact information and talk a little bit too how we run things in our clinic. We are pretty much available all the time. I will literally always pick up my phone. Dr. Final picks up his phone time. Nikki, our team lead, I call her the boss. She literally always has her phone. I'm sure as many of you know, we are very focused on helping the athlete as quickly as possible. There's a lot of days where if y'all call us, we'll get them in clinic. We might have them have an MRI the same day and literally come back across the hall and get them ready for surgery, get them set up for PT, whatever it is that needs to be done. So we are absolutely here for you guys, here to serve y'all. I will start seeing patients on Tuesdays and Thursdays. Not yet, but eventually when Dr. Primal is, when he's in surgery on Tuesdays and Thursdays, I will be in clinic. Again, I'm very easy to reach. Maybe not like 2 o'clock in the morning, but all other times. But if you need any additional information, I also have our cards and our office number up here as well. But just want to talk a little bit about that and our process. These are some additional resources for prevention that I spent a lot of time reading through. These are just great prevention programs for athletes. Of all these websites, some of them are from the Australia Soccer Federation, Sports Metrics. They just go through all the exercises. There's some videos on there just about prevention, dynamic warm-ups, strengthening exercises. And I think they're great resources. I think they're resources that honestly, especially athletes in the preseason, everybody could benefit from. But I think, especially with our female athletes and knowing now their increased risk factors, it's really important that we're paying attention to all those things, that we're making sure their programs are sport specific, they're doing the strengthening, they're doing the conditioning. Again, you guys see them way more than we do, so y'all are in charge when it comes to that stuff, but I think some of these resources are great for them and will really make a difference. Any questions I can answer?
Do you know if there's any research about the effects of birth control on all of this?
Yeah. So that's something I've been reading about as well. There's a few places that have done some research on it, and especially like the oral birth control pill. There is a lot of positive correlation that could help when a lot of these hormonal fluctuations, because, young females, young athletes, they don't have a period, they may not be pregnant, but their fluctuations of hormones increase greatly. And so they're right at that high point where that is super high. That's kind of what that PIPA study is looking at to see if we can figure out how to decrease training loads, things like that. But I think medically as well, the birth control will play a pretty big role in that. I definitely think it makes a difference. I think, it's a little bit more of not just athletics, but obviously with young female athletes and conversations between parents and primary care providers. But I think if we have as many female athletes as we do, playing sports, not having rest or specializing in one sport, I think it's definitely gonna be beneficial in the future if they can be on it.
That's something I know, I feel like a lot of our kids are already.
Mhm.
That's what I'm wondering. in the future, you know.
Yeah, and like I said, there has been a lot of research on that, and I'll be interested to see kind of what the FIFA study shows and some other stuff coming out that says, are we seeing strong enough positive correlation to recommend this to, a lot of our younger female athletes? I think. Yeah. Not that I've seen necessarily, but I think it will come down to, with some of this, like the hormonal stuff and the people study tracking kind of like blood levels. It won't necessarily maybe a medical management, but a training load and prevention. If we can start to see what this research looks like, then, if we can monitor that, and it might further down the road how we will monitor that in our female athletes, but I think it's going to be one of those things where it's gonna come down to training load, practices, not having high intensity practices during those times, during that kind of menstrual cycle, whatever it may be. If some of those athletes are saying those things or bringing it up to a coach or whatever else, maybe their training load is a little bit lighter that day. Maybe do more skill work and the team practice. So I think that's something that we may see in the future. Well, thank you guys. I really appreciate it.
All right, before y'all get out, I'm gonna do some recognitions real quick. We try to recognize great performers. So, first of all.
Thank you.
These are employee recognition. So I think most people, but you're supposed to get one of these as an